Hey, Herd. Well, welcome to another episode of the Healthcare News Roundup. How you doing?
I'm doing good. Lots of good stuff going on.
Man, there's a lot going on. Okay, today we picked a handful of stories that Herd and I both like and think are pertinent. And so the whole point of this is to kind of just give you some news that we think is interesting. And so let's go. So there's a fellow, the CEO of Tenet, Dr. Sam Sutaria, probably one of the smartest people I've ever met in my life. There's a quote that talks about the hospital volume projections to potentially slow or certainly get steady in 2025. Here's his quote, Herd. Let me tell you that. After weathering a few years of COVID-19 interruptions, hospitals are now riding a wave of strong demand for acute care services. Second quarter earnings from several major health systems have outlined year-over-year gains across several patient volume metrics. Industry-wide data reports have outlined a similar demand recovery trend as well as the accompanying revenue gains, but the recovery can't and won't last forever, warned Sam. What do you think about that?
Yeah, I think it's this. We've seen the kind of trough in 2021 and the post-COVID volume issue and really the inflationary cost issues. And finally, it seems that sort of normalized a little bit. As costs have, revenues caught up a little bit with new managed care contract negotiations, and so you're going to see this current volume probably crest, and then we'll see what happens. I think the large publicly traded systems, especially, are on solid footing. We see that. We see the large systems, doing well, and it sort of weathered the storm. And I think we're going to continue to see in 2025. They've kind of got everything in place to hopefully weather the volume downturn if there is one. But then this may be further shakeouts for smaller systems, less well-run systems. That's what will be interesting to see.
Yeah. Yeah, no, I agree. Okay, so let's go to the second one. This one to me is extremely sad, and it's a dwindling geriatrician pool available. And so I'm not going to read the whole excerpt of this article for you. This was in Modern Healthcare on the 5th of September. And it's talking about the number of board certified geriatricians is on the decline. It fell from 10,270 in 2000 to 7,413 in 2022. Overall, it's just a dwindling pool and availability of internists that are specially trained in geriatrics. Any thoughts on that, Herd?
Yeah, it's kind of interesting. I mean, you have a declining, geriatric specialty pool, but with an increasing, elderly population. So that's just going to create more issues. I thought what was interesting in this story from Modern Healthcare is, I believe, out of 174, 419 geriatric medicine positions at medical schools, 174 were accepted. So, I think there's just a not the interest of people going into that field. One of those, and this is where, economics should say, increasing demand, decreasing supply, we should pay these people more to get more people interested. But with some of the way the healthcare economics work and compensation, it doesn't respond as readily to those types of market forces as other things do. And so then you're left with this imbalance that occurs.
Yeah. So to me, this is going the exact opposite direction of what should happen. We've got the boomers that are going into their seasoned veteran years. Their healthcare utilization is going to go way up. We should absolutely have way, way, way more geriatricians. But as docs are coming out of training, the revenues are not there. The comp model does not say so they're going into cardiology or they're going into surgery or they're going somewhere. They're not going here.
Yeah, a more responsive, market would fix that in terms of, the reason the compensation isn't there is because the revenue for those types of services isn't there.
Right.
And to me, that indicates some sort of mispricing in the healthcare market. And I think you see that all the time because you have an environment where prices are fixed at some level or they don't respond as readily as they do in other areas. So kind of fascinating and also from an economic standpoint, but scary as well from a need standpoint.
Yeah, no, I just didn't like that story whatsoever. Okay, let's go to the next one. This is private equity deals and really talking to physicians that are considering a PE deal and the tax considerations for that. So a great article out of AHLA, Health Law Connections. And it just, let me just read a quote for you there. This article discusses important corporate and tax issues that parties to a private equity affiliation need to consider when negotiating, structuring, and entering into a transaction. And it goes on, but it just says, and there's tons and tons of meat to this article, but it just says that as docs consider PE things, there's a lot of tax considerations personally and corporately for their practice to consider. What do you think about that one?
Yeah, I think, anytime you're dealing any type of complex transaction, you want to make sure you understand not only the way money is flowing in that transaction, but what are those tax implications?
Yeah.
Especially with things like the way personal goodwill versus corporate goodwill, the way that's taxed, there's different ways. And so when you're doing a transaction like this and you're allocating that purchase price, there's a lot of work to be done to make sure that you're allocating in a way that's legal and ethical, but also takes full advantage of what what's potentially there from a tax standpoint.
Yeah.
The article does mention that both parties cooperating can make some of those changes on the front end or make some of those decisions on the front end that will help both parties. And so again, it's just keeping your eye open and on the ball and making sure you've got good advisors around you who can help navigate those complex tax waters.
Yeah. Yeah. Well, I mean, it's a big enough decision to kind of do a deal with PE, but it's even more complex when you're thinking about your own personal tax implications as a result of that. So my advice is to do exactly that. Get good counselors to advise you there. Let's flip over some M&A work. So this is interesting. It talks about Henry Ford Health System taking over 8 Ascension hospitals in Michigan. Now, Ascension's still going to have, I think it was 4, but it was in Southwest Michigan. Henry Ford and Ascension are forming what sounds like a JOA. I didn't fully understand the structure, but basically those Ascension hospitals are being attributed over in the greater Detroit area to Ascension. To me, in looking at that says, and all kind of national healthcare nerds like us are saying, well, Ascension really is really tightening up to about 4 markets now, as opposed to this giant, colossal system. They're really tightening down to 4 markets. What do you think about that, Herb?
Yeah, I thought it was interesting. It's a no cash transaction. So again, don't really have the details about how that's going to work. But I think this is a sign of, trying to hone in on where your core markets are and where you want to operate. And again, trying to focus probably in getting ready for, potential changes that are occurring next year, as
Right.
We said in the first story.
Yeah. Yeah. Okay. Well, let's go to another scary one. So this is around the OIG, and the OIG is publishing real estate related self-disclosures nearing $2 million in liability. The one quote that I want to highlight here, the instances that the OIG published included healthcare entities paying a physician group above fair market value rates for space, equipment, and lease staff, providing space to physicians for free or below fair market value rates, and sham lease arrangements. Sham, I mean, that's an old 1920s term, Heard, but that doesn't sound good at all, right? So
yeah, I mean, this goes back to our old friend Stark, anti-kickback, and in any transaction, if a physician provider group has some sort of referral relationship with another entity, any type of financial transaction they do needs to be fair market value, needs to be looked at and blessed by legal counsel, by everyone who's involved, to make sure that you don't find yourself in some sort of arrangement that's deemed illegal. I mean, essentially, if you are a provider or a physician and you own office space, you deserve fair market value rent, but not above that.
Right.
Conversely, if you're using space from a provider or from a hospital, then you want to make sure you're paying fair market value rent and you're not paying below rates. And so again, it's just, keeping your eyes open, making sure you are cognizant of the traps that you can fall in, and just trying to do things above board.
Yeah. Yeah. No, good counsel. So, and this can catch you years after the fact. So I don't think the OIG is terribly worried about any time frame. If they find it and see it, they're gonna get after it.
Yeah,
so
absolutely.
Here's one that I think the whole nation has been tracking, and that's really around Steward Health. Most people have seen that it's gone into bankruptcy, and Dr. De La Torre, the CEO, has come under tremendous scrutiny. And so Dr. Della Torre, the CEO of Steward Health, has refused to testify with a Senate inquiry. And it's just really shocking. And so there's all kinds of subpoenas with him, but he basically has said that this is what it says. The letter said to respect the ongoing settlement and restructuring process by remaining silent regarding the reasons for Steward's bankruptcy. Again, just more fodder for media to attack Steward on this, right, Herb?
Yeah, I mean, this has kind of become a media story. There was a big story in the Wall Street Journal a couple of weeks ago about this. I mean, there's been multiple stories in the Wall Street Journal, but I think it'll be interesting to see how this continues to shake out. I know the Massachusetts hospitals have recently, I think the deal finally closed to sell those, but as Steward sort of unwinds these hospitals, but they now have the interest of Congress and others who are looking into what happened, and so this will be one that we continue to follow.
Yeah, no, absolutely. And some of it is very sad because some of these are community hospitals that are taking care of communities in kind of rural and, kind of just parts of the U.S. like Ohio that desperately need these facilities, and they're closing because of mismanagement, unfortunately. The last is yet another sad story. I feel like I've got plenty of sad stories today, Herd. This is another one that I don't like at all. And it's called the crushing financial burden of aging at home. We've talked about over time that Americans want to grow old in their home. And what we're finding is there are this article says more than 11,000 people in the U.S. are turning 65 every day. And many of them want that round-the-clock care and need that care. And unfortunately, that care can cost around, on average, $290,000 annually. And so this report in the Wall Street Journal on the 4th of September really describes this and just says most people can't afford but maybe a year of that, but then that's it. And then they have to revert back to being at a home or at a nursing home or really having subpar care. So again, just another really, really sad term, right, Hurt?
Well, I think it's depending on the level of care that's needed, it's going to be expensive if you need round the clock care at home and you're not sharing, somebody with multiple people. I think this is the result of that.
Yeah.
I think again, I hope that the market can be innovative. We've talked a lot about hospital and home. This isn't quite the same thing, but if there's a demand out there, we have an increasing aging population. And if demand's big enough, there'll be somebody who comes along to figure out a solution to that. And then hopefully you see those costs come down.
Right. Okay. So maybe next news roundup, Heard, you and I'll be a little bit more chipper. Today, it seemed like there were kind of some dark stories, right?
Always, healthcare is you're dealing with life and death, and you're dealing with people. So
right.
It's just like the human story. It's full of joys and tragedies. And so
that's right.
The way it works.
Well, thanks for joining me. We'll talk to you guys soon. Take care.